So we are back online. I hope everyone had a tasty lunch and good lunch and are ready to listen for a new presentation. And I'm really glad to introduce Dr. Abigail Easter. She's from School of Life Course Science, Faculty of Life Sciences and Medicine at King's College, London, United Kingdom. And her research focuses on maternal and infant health, particularly addressing maternal mental health disorders, perinatal mortality, and the integration of care between obstetrics and mental health services. And that is today the first presentation on this topic. It will be followed by my colleague's Agla's presentation about the situation in Lithuania. But now, Abigail, the screen is yours. We are looking forward to hearing you.
Wonderful. Thank you so much for the kind introduction and invite to talk today. I'm really looking forward to presenting and sharing some of our research from the UK. So as mentioned, I'm based in the United Kingdom, in Southeast London, and today's talk I'm going to be focusing around kind of issues of maternal mental health and the impact on suicidality, and hopefully thinking about some of the potential prevention strategies and what kind of prevention strategies are in place currently within the UK. So just to give a bit of a background on where we're really going with this talk, I'm going to talk generally about the maternal mortality data and rates within the UK, with a focus on the trends in maternal suicide and some of the characteristics that are associated with maternal suicide and suicidality. I'm going to spend a bit of time talking about some of our research that we've conducted recently, which has had a real focus on listening to the experiences of women and family members. And as I said, hopefully consider some of the prevention strategies and how these might be applicable or not to the perinatal period. So we know from the World Health Organization data that approximately 800 women die from preventable causes related to pregnancy and childbirth every day. And maternal suicide is often one of these important causes of maternal death. It's often overlooked and not talked about as much as some of the other causes of maternal deaths. Despite this, it's a leading cause of death within the perinatal period in many high-income countries. And data shows that this might range between 5 to 20% of all maternal deaths. So it does make a big contribution to the maternal death rate. There's some indication that this might be lower in low and middle income countries, with recent data suggesting that approximately 1% of all maternal deaths in low and middle income countries might be related to suicide. But we know, and I'm sure this has been touched on, that some of these potential differences in data and in statistics are often due to the terminology and classification, both of suicide, but also of maternal mortality. So when I'm talking about maternal mortality data from the UK, we talk about and we measure deaths that occur during pregnancy and shortly after pregnancy, so up until the first few months postnatal, which are considered early deaths, or in the following first year following birth. And the maternal mortality in the UK is measured both looking at those that are directly related to pregnancy and childbirth, as well as those that are indirectly related. So this graph just shows data from the recent Embrace inquiry in the UK. And in the UK, we have annual reviews of all causes of maternal mortality that have occurred in the previous 2 years. So I'm going to be showing some of that data just to really look at the contribution that maternal suicide and some other psychiatric related causes of death might make to that. So the overall maternal mortality rate in the UK is around 13.5%. So we know that fortunately maternal mortality is rare. However, maternal suicides contributes around 0.8 0.89 per 100,000 maternities to this rate. And when we look at all-cause mortality, so those occurring during pregnancy and in the first year postnatal, we can see that psychiatric-related causes, both those from suicide and those related to drug and alcohol use, actually contribute the fourth leading cause of maternal deaths within the UK. And this is particularly the case when we look at those late maternal deaths, so those which are occurring between 6 weeks and 1 year after the end of pregnancy. Approximately a third of the deaths occurring in this period are either related to suicide or drug and alcohol use in the postnatal period. So I just want to focus on some of the characteristics of the women who died from both suicide and from substance misuse in one of the latest Embrace reports. And as I mentioned, the numbers are small, but there are some consistent characteristics across these groups. So in the recent report, what was identified was there was a concerning increase in the number of women dying from suicide who were under the age of 20. We also see, when we look at the level of social deprivation amongst those women who died from both suicide in this column and deaths from substance misuse in the far end column, that when we look at the deaths amongst these women, a huge proportion actually are living within the most deprived areas of the UK. And this is particularly the case for those who died from substance misuse. Again, another important factor that I'll talk about a little bit more is domestic abuse occurring during pregnancy. So what the data from recent and past Embrace inquiries has shown is that domestic abuse occurring both prior to and during pregnancy is common amongst those who died. So we can see that around 70% of those women who died from substance misuse in the perinatal period had been experiencing domestic abuse prior to or during their pregnancy, and around 30% of those who died from suicide had been experiencing domestic abuse during their pregnancy. Similarly, we can see, building on the theme of social complexity, that a large proportion of these women were also known and under the care of social services within the UK. So this might be for providing additional social care support and also potentially assessment of risk to the family and to the infant due to safeguarding concerns. And again, we can see here that around 85% of those who died from drug or alcohol use were known to social services, and just over 40% of those who died from suicide were known to social services. And within the Embrace inquiries, they do also a very detailed examination of the quality of care that women have received. So it's a very detailed look at both their maternity notes, their obstetric notes, and their mental health care notes. And this is assessed against their standards of care that should be being received according to NICE guidelines. And again, we can see that actually a lot of women aren't receiving the recommended level of antenatal care who died from suicide or substance misuse, and potentially lots are not receiving even the minimum level of antenatal care. So around 65% of those women who died from suicide were deemed not to have received the minimum level of antenatal care within the UK. So I think that highlights that there's some kind of common trends amongst the women who died from suicide and drug and alcohol use in the UK. One of the things that has also been shown from this data, and there's really strong evidence for, is around kind of the timing of maternal deaths and the relation to loss of a pregnancy, either from miscarriage or stillbirth, so pregnancy loss, neonatal deaths, but also from loss of a child through to from removal by social services in the postnatal period. And what these graphs show is the timing of death across the antenatal and postnatal period in the top graph for those who died from suicide, and in the bottom from those who died from substance misuse or other psychiatric causes during pregnancy or the postnatal period. And what we find is that generally the postnatal period is that of increased risk. In the hatched bars, you can see here that these are the number of women who died following a known loss. And again, we can see that there's quite a high proportion of those who died from suicide following a loss of pregnancy or of their child. And substantially amongst those who died from substance misuse or other psychiatric causes, you can see that in the 6 to 9 months postnatal period, that a very large proportion of those who died subsequent to a loss. And when this is broken down in terms of the types of losses that are experienced here, and they've also looked at threatened loss. So this typically includes women who were undergoing social care proceedings, potentially to remove their child into the care of social services, but who died prior to the baby being removed. You can see here that around 60% of the women who died from substance misuse died subsequent to their child being removed or threatened to be removed. And there's also a relatively high proportion of those women who died from suicide who are experiencing various kinds of pregnancy or perinatal loss. So here again, it really demonstrates the importance of considering some of these pregnancy or postnatal related factors that might be contributing to suicide or deaths from substance misuse. In the recent report, I just wanted to highlight this because there has been some questions about whether maternal deaths from suicide are on the rise within the UK. As I mentioned, fortunately, they are relatively rare, but what we did see within the report in 2020 was that there was a threefold increase in deaths from suicide in the 6 weeks and year up to a year postnatally. So there have been some concerns that's been increasing. I think it's probably too early to say if that's anything that we should be concerned about just because of the low numbers, but it's definitely something that's been highlighted for us to really be aware of. In this editorial piece that we wrote reflecting on the deaths from suicide and this increase in 2020, what we found was not only that the deaths from suicide were increasing, but the characteristics of the women who died from suicide seemed to be changing over time as well. So there was a large number of women in this more recent report who died from suicide who had very complex needs, so patterns of domestic violence and abuse, as we've seen, children at risk of being taken into care, and many of the women had long-lasting history of trauma. As I mentioned, there was a slight increase as well in the number of women under 20 who died from suicide-related and psychiatric-related causes of deaths. And actually, for all of the women who died from suicide who were under the age of 20, all of those had previously had their child taken into social services prior to their death. So it might lead us to think whether the perinatal period is an increased time of risk for suicide. And actually what we know is it's quite clear that in the general population, the perinatal period is really thought to be quite a protective time against suicide. So we can see here that the rates of suicide amongst females in the population does slightly fluctuate according to the age range. And also studies have shown that in the perinatal period in the general population, they tend to be around 20-fold lower compared to matched non-pregnant populations. So this has been quite a robust finding that in the general population, actually the perinatal period and particularly pregnancy is actually a lower time of increased risk for suicides in the female population. But this sadly isn't the case for all women, and as in the general population, we know that the risk of suicide amongst women with moderate to severe mental illness is dramatically increased. In one of the first studies that really looked at this, and this was a study conducted by Professor Lewis Appleby in the UK, they found a 70-fold increased risk in suicide in the first year postpartum amongst women who had a postpartum psychosis. So really, for those women who are experiencing a sudden rapid deterioration in their mental health in the postnatal period, the risk really is dramatically increased. And I just wanted to draw on some data from a Danish registrar-based cohort study, and this was one of the largest studies that's looked at this, and they conducted a cohort study using data from over 1.5 million women. And as you can see here, again, just highlighting that the numbers are small, but the increased kind of relative risk is short-term risk. So in the first year after diagnosis of a postpartum psychiatric disorder, there is a very high substantial risk that we see in the year after diagnosis, and in non-postpartum onset disorders. We can see that actually this risk is much lower. So there's a group of women that we know are particularly high risk, and those who have a diagnosis of a postpartum psychiatric onset disorder, and they're particularly at risk within the first year after receiving their diagnosis or becoming unwell. There's also some important characteristics about perinatal suicides that I wanted to highlight compared to non-perinatal suicides, and this is also reflected in the EMBRACE data and has been since the EMBRACE inquiry started over 10 years ago. What the data shows is that perinatal suicides tend to be more of a violent nature compared to non-perinatal suicides. And this is data from the National Confidential Inquiry into Suicides and Homicides amongst people with mental illness. So amongst this kind of high-risk population, again, we can see that deaths from suicide from more violent measures are substantially increased compared to non-perinatal suicide. So women of a matched age, group control, but not within the perinatal period. In terms of the suicides by psychotropic overdose, the study also indicated that this was higher within the perinatal period compared to outside of the perinatal period. There's also been several studies that have really looked at kind of the characteristics of contact with mental health services amongst these women. So amongst these women who had contact with mental health services, again, we can see, this is reflected in the data, that they were more likely to have a shorter duration of mental illness and a primary diagnosis of depression compared to non-perinatal women. A history of recent alcohol use, and as we've seen, more likely to use a violent suicide method. One of the important things that's come out of this study, and again has been reflected in other studies, is that they were much less likely to be prescribed psychotropic medication at the time of their suicide. And one of the risk factors that's come from the EMBRACE inquiries and other research is that during pregnancy, women may be more likely to abruptly stop medication, and particularly stop medication without the support of healthcare professionals, which can lead to a relapse in mental health difficulties, and also increase the risk of experiencing postnatal episodes of mental illness. So it's really important to kind of highlight the importance of discussion around taking medication during pregnancy, just to be balancing those risks of continuing with medication and any potential risks or concerns about risks of harm to the pregnancy or baby, along with the risk of relapse and potential deterioration of mental health in the perinatal period. So I just wanted to briefly move on to talking about suicidal ideation and behaviours in pregnancy. There's been some data which has shown that the prevalence of attempted suicide during pregnancy is substantially higher than the deaths from suicide. So this data showed that around 680 attempted suicides per 100,000 during pregnancy, and 210 per 100,000 in the first year postnatal. So the risk of attempted suicide we know is higher, although still outside of the perinatal, it's still lower than compared to outside of the perinatal period. There was a very detailed systematic review which looked at the ranges of self-harm in the general population compared to those with severe mental illness. And again, this study reflects some of the previous data that I've shown, that the risk for self-harm during pregnancy and in the first year postnatal is substantially reduced amongst in the general population compared to women with severe mental illness. And you can see here the range across studies is quite varied, and again, this is largely due to both terminology used and the populations under study. But those who had a postpartum, particularly postpartum severe mental illness, were more likely to experience self-harm in the pregnancy and the first year postnatal. There's also some data that's looked at suicidal ideation during pregnancy, and there is a suggestion, and we're not quite sure the reasons behind this or the mechanisms, but that suicidal ideation may increase during pregnancy in the general population, as well as those with severe mental illness, compared to the non-perinatal period. So again, just really highlighting that there might be some contextual factors or factors during pregnancy and the postnatal period that we need to be aware of that are contributing to suicidality. So I just want to move on to looking at some of the considerations around the support that women might receive following admission for self-harm during the perinatal period. So in the UK, we've had quite a wide expansion of perinatal mental health care over the last 10 years that has really increased provision of specialist perinatal mental health services that are delivered both within the community and mother and baby units, as well as kind of recognition of some of those risk factors and need for support. So this was a study we conducted which looked at women who had been admitted to a medical, so a non-psychiatric setting following self-harm. And this didn't include those who were presenting an accident and emergency alone. It was those who required an admission for longer than 24 hours, either for monitoring of their condition or for treatment. And we linked this data to look at the characteristics of their mental health care, as well as some of the factors that surrounded those admissions. And just to say, this data comes from just over 17,000 women. And when we look at this data, what we found was that there were 448 admissions during this period for self-harm. And often there were repeat admissions. So for over 140 women, they had more than one self-harm admission during the perinatal period, either a current or subsequent pregnancy. And the vast majority were admitted following self-poisoning, or had an ICD code of self-poisoning or overdoses within their medical records. And again, we can see that admissions during the postnatal period were slightly higher, and those admissions during pregnancy were more likely to occur within the third trimester of pregnancy. There was a high rate of previous self-harm amongst this group, and also a very high level of previous contact with secondary mental health services. So again, we know these people might have quite long or severe complex histories of mental health or suicidal behaviours, with around 9% having a psychiatric inpatient admission in the year prior to their admission. Interestingly, what we found was actually the assertive follow-up of these women after their admission was quite poor by comparison. So only 30% of women were seen by mental health services within 7 days. And only 25% had kind of contact with mental health services within 24 hours of their admission. And we would expect that some form of contact with mental health services for assessment for self-harm. So I think this is really highlighting some of the difficulties between services that I'll come on to talk about. And it's important to think about that suicidal behaviours during pregnancy may also have a potential adverse impact on the pregnancy and on the birth outcomes. And just to highlight findings from one study which found a significant increase across a range of adverse pregnancy outcomes, including hemorrhage, spontaneous delivery, preterm birth, stillbirth, and poor fetal growth, compared to those with non-suicidal behaviours. So again, we know that this relationship might be confounded by other factors such as the mental health difficulties themselves and social deprivation. But even after controlling for many of those factors, they found an increased risk amongst those who had suicidal behaviours during pregnancy. So this is something to be just aware of. And I know we talked a lot about risk factors for suicide. And the risk factors for perinatal suicide, there's much overlap with risk factors outside of the perinatal period, and the factors can span individual, socioeconomic, environmental, gestational and clinical factors. But I just wanted to highlight some of the factors that are particularly relevant and important to be thinking about during the perinatal period. So exposure to domestic violence and abuse, partners who rejected paternity, as well as other factors such as unwanted and unintended pregnancies, and previous kind of history of suicide ideation and suicide attempts. And in terms of domestic violence, which is an area, a really important area to focus on within the perinatal period due to its relationship with suicidality, so domestic violence and abuse in the perinatal period occurs in around 4 to 8% of pregnancies, and it's consistently associated with an increased risk of suicidality in the perinatal population as well as outside of the perinatal population. And when we look at the increased risk for those with emotional, physical or sexual abuse that have been experienced during pregnancy, we can see that this does increase the risk with odds ratios of around 6% for those experiencing physical or sexual abuse. And other studies have indicated that it's associated with an increase of over 9 times the risk, and that a large proportion of those who are experiencing domestic violence or abuse makes a large contribution to the proportion of mothers who die from suicide. So moving on from talking about the data, I think over the last kind of 10 years of research in the UK and internationally, there's been a real picture that's built up to help us understand the nature and the context of suicide and suicidal behaviours during the perinatal period. But there's a real lack of understanding about what the experiences are of women, of families who might be experiencing this. And so I just wanted to focus a little bit on some of the qualitative research that we've conducted recently, and data from the ASPEN study, which is a study of attempted suicide in the perinatal period. And what I'm just going to be focusing on today, so we were interested to explore the experiences of women who had experienced one or more suicide attempt during pregnancy. We have also interviewed their significant others, so partners or other family members, and looked at recommendations for care. But I just want to focus in on the experiences of the women today. A brief note on terminology. So we looked at suicide attempt using a definition of a non-fatal, self-directed potentially injurious behaviour with an intent to die. So the combination of somebody having a suicide ideation, intent, and behaviour, although the suicide attempt may or may not have resulted in physical harm. We interviewed 11 women for this study, and across these women, what we did find was that actually, in terms of recruitment, the women were relatively well educated, most frequently from a white English background, in a married relationship, and had a planned pregnancy. So they are of a slightly higher socio-demographic characteristic than the women that I previously been describing in the Embrace report. Having said that, many of the women had multiple mental health diagnoses, with a small proportion experiencing psychotic mental health difficulties, and the level of mental health care received by these women following their suicide attempt. Many were being seen by psychiatric services, either inpatient or mental health services. And again, we interviewed a woman who had a range of different suicide attempts, that many of which had been prevented either by a healthcare professional or a family member. And we identified 3 key themes relating to their experience, which I'll talk through briefly in the next few slides. But we saw a high level of trauma and adversity, a disillusionment with motherhood, and this often for many women led to a sense of entrapment and despair about their current situation. So the first theme relating to trauma and adversities, what we found is that for all of the women we interviewed, they were experiencing a high level of psychosocial adversity. Many were experiencing domestic abuse or violence, and many had a family history of perinatal mental illness. So I won't read all the quotes, but I'll just highlight some of the important things from what the women told us. So this lady Sarah on the right, she talks about how her mum had a severe perinatal mental illness and was hospitalised after her older brother, and then again after herself when she was born. So she was aware that this had happened. Her mother sadly died from suicide. So she was aware that this collective history may become a factor when she became pregnant. So actually she had been receiving care prior to pregnancy, and referred to the perinatal psychiatry team. And again, you can see the quote from Rosie. She talks about her mother experiencing different things, and herself experiencing big things in her life that may have contributed to this. The second theme of disillusion with motherhood, I think, really is summed up in one of the quotes that one of the women spoke about, it feeling not like starry-eyed love. And I think there is this real pressure on people to kind of be glowing and blossoming during the pregnancy and postnatal period. But what many of the women told us is that they experienced a lot of physical health struggles, a lot of mental health struggles. Some had experienced very traumatic births. And this often felt that when they were receiving care, it led to an invalidation of their identity and their self-sacrifice. So as this person talks about, it was never about me. And I know it's not all about me, but when I'm wanting to commit suicide, it's very much about me. And not one person asked if I was all right. They were more concerned about the baby and how the baby was. And this was a common theme throughout, where the women who were suffering with severe mental health difficulties, suicidal ideation, really didn't feel that there was ever the opportunity to talk about themselves. And the final theme really highlighted how this led to women feeling very desperate, often feeling quite trapped within their situation. So feeling like a failure at motherhood. Some of the women experienced very intense, intrusive thoughts or abnormal experiences. Some were related to psychotic episodes. Others were related to obsessive compulsive thoughts. But they described feeling very alone in the world. And they described how sleep deprivation and not sleeping during that period really led them to feeling exhausted and quite trapped in the feeling of motherhood. So as this woman talks about, I stopped sleeping entirely. I was so angry all the time. It was all textbook depression, but I was so angry all the time. I was just so tired. I couldn't sleep. And what we found was that in terms of the irreversibility of motherhood, that many found that they were then in this situation where they were feeling trapped and like a failure, and really feeling that there was no way out of that situation. And again, as this quote from Sam highlights, she talks about it getting so bad that it got to the point where prenatally she just generally would hope she wouldn't wake up the next day, because it was another day closer to having a baby. And this was just in the weeks prior to her suicide attempt. So just reflecting back, we have done some analysis of the quality of care those women received as well. But I'm going to reflect back on some of the Embrace findings from those women who died from suicide, because we know that quality of perinatal care is important. And as I mentioned, a large proportion of those women didn't receive adequate maternity care. And when we look across mental health care and all care received, only 8% of women who died from suicide or substance misuse were deemed to have received good care according to clinical guidance. And around 70% of the women who died from suicide and 35% of those who died from substance misuse, it was deemed that improvements within their care could have made a difference to the outcome, and may have been preventative against the outcome. So quality of perinatal care, quality of care in general, is an important factor. And this leads me on to talk about the suicide prevention strategy in England. So last year, we recently had the new suicide prevention strategy, which was published, covering the period between 2023 and 2020, with clear kind of priorities for action and clear priorities for targets set out within this. And this has really led to huge changes within the UK. This the previous suicide prevention strategy and the current suicide prevention strategy. And the priorities for action that I've just highlighted here on the slide really, as you can see, are about taking a collective response to suicide prevention, improving data and evidence, including tailored and targeted support for priority groups, as well as more population health prevention strategies, such as reducing access to means and methods of suicide, and really a kind of ask for societal change around making suicide everyone's business. In the most recent National Suicide Prevention Strategy, pregnant women and new mothers were included as a priority group for targeted prevention for the first time. So again, as I've kind of highlighted, although the rates are low, we know it has makes a significant contribution to maternal mortality, and we know that the effects of suicide in the perinatal period can be tragic for family members and wider society. So the targeted recommendations within the suicide prevention strategy for pregnant women and new mothers include expansion of maternal mental health services. And as I've mentioned, we have really seen an increase in provision of support for maternal mental health care within the UK. Identification of risk of mental health and other risk factors in pregnancy. We have routinely asked questions at booking appointment that can be used to identify risk. And again, I'll come on to talk about some of the difficulties with those. Assessment and support at every contact. We know during pregnancy and the postnatal period that women often have increased contact with healthcare professionals. So they're likely to be in contact with their general practitioner, with their midwives, with obstetricians, and also many may be under the care of mental health services. So there's a real opportunity to provide care and support for those at risk. Another factor that's really important and has kind of come out from some of the research is this information sharing between services. So although it's a huge opportunity to intervene, we know that that kind of complex involvement from multiple healthcare professionals actually can lead to things being missed when there isn't adequate information sharing between services. And some of the important factors around kind of recognising the perinatal context that may be contributing to an increased risk of suicide. And Embrace highlights some of the kind of key factors which they call red and amber flags that may indicate an increased risk and a need for enhanced care. So these are common themes that were found amongst all the women or many of the women who died from suicide during the perinatal period. And what's suggested from this research is that any new sorts of self-harm in the perinatal period, a sudden onset or rapid worsening of mental health, particularly within the context of postpartum psychosis, and persistent feelings of estrangement from baby, should lead to a rapid assessment and intervention in the perinatal period. Other factors that require an enhanced level of support include a past history of psychosis, as well as a family history of bipolar disorder and postpartum psychosis, which we know both increase the risk of postpartum psychosis, along with personal and family patterns of mental health. So really taking into consideration that wider context of mental health difficulties. And I think it's sometimes can be challenging to move between the strategy and the proposed approaches to reducing the risk of suicide, and thinking about what this actually looks like in practice, and actually how complex and difficult suicide prevention can be. So some of the key factors that are starting to be implemented, or we're starting to see more widespread implementation within the UK, are really around an individualised approach to assessment and care, reducing the barriers to accessing mental health treatment and support. So even though the services are currently in place, we know that there is inequitable access to those, particularly for those from ethnic minority groups and those experiencing social disadvantage. Better multidisciplinary awareness and training, both around suicide prevention, but also training in perinatal mental health for general practitioners and those working in general adult mental health services. And as I kind of mentioned, improved communication is really important, and just really greater availability of that kind of social and psychological support for those during the perinatal period. So it's easier said than done, I think. There is a lot of work to be done, and particularly around kind of what interventions and what strategies are going to be effective and acceptable to reducing risk. So in this study, we looked at kind of barriers amongst healthcare professionals to providing responsive care to women who were at risk of suicide or suicide attempts during the perinatal period. And they really emphasised this kind of difficulty of recognising the severity of risk, and how across different disciplines, risk is very much interpreted differently. So the midwife spoke about, seeing women who they felt were at a very high risk level and referring them on to mental health services, but the mental health services not seeing the risk in the same way, and the women not meeting the threshold for support from mental health services. There's also this huge difficulty of communication with risk, not just because of the different languages that various healthcare professionals use, but also due to practical things such as the different IT systems where records are kept. And the quote from the midwife on the right talks about how nothing speaks to each other, and that's very much the case in the UK. So the mental health teams can't see what the midwives have written, they can't see what the mental health team are written, and social care can't see what any of us are writing. And that was a comment from the midwife, really to know how that, if something has occurred in a different setting, how that risk is communicated between services. There's also a difficulty around screening measures, particularly for suicidality. So again, in the UK, we have a routine assessment for mental health. So every woman at their booking appointment will be asked standardised questions around their mental health. But we know that these are going to pick up a larger group of women. Some may require secondary mental health services, and some may not. But they're not necessarily predictive of the risk of suicide or suicidality. And this recent study here is really showing that when the items on suicide screening questions, so for example, the Edinburgh Postnatal Depression Scale is used quite regularly, which has one question relating to suicidality. And they found that actually the vast majority of maternity healthcare professionals feel uncomfortable asking these questions. They dislike it, and they find the questions unhelpful. Data from women also echoes this really, and in the general population and amongst those who have suicide ideation, find that some of the questions are currently unacceptable in their current form. So I think there's a real question about if we're going to introduce universal measures that aren't acceptable to the majority of people asking them, what impact that has on kind of identification of risk. One of the largest factors we know is that stigma, fear, and shame are central to non-disclosure. So, particularly in the perinatal period, women are very concerned about how this might reflect. They're very worried about involvement from social services and the impact that might have. So just to kind of summarize, I think what we see from the data and the data that's emerging is that although suicide is lower in the perinatal period in the general population, it remains a leading cause of maternal death, and it's dramatically increased amongst those with mental health conditions and those who've experienced a history of domestic violence and those with reproductive vulnerabilities, particularly those who've experienced loss. And those with a recent onset of mental health conditions might be particularly vulnerable. So I think it's really important, as I've mentioned, to be thinking about the perinatal context and what implications that might have to help us kind of reduce barriers to care and to really start thinking about how we can better communicate between health and social care teams, which is going to be, I think, essential to reducing future deaths from suicide. So I just wanted to finish by highlighting this recent paper and really the legacy of Daska Emerson in the UK. Daska was a psychiatrist in London who sadly and tragically died from suicide along with her baby Freya at 3 months postnatal. And really the learning from Daska's experiences has led to an increased kind of understanding, I think, of where the gaps in services are, particularly around medication use and the need for mother and baby units universally. Daska had a history of bipolar disorder, but had been very stable prior to pregnancy, but had decided to stop taking medication during pregnancy for the pregnancy, and so as she could breastfeed her baby, but this led to a very severe relapse within the postnatal period. So I just wanted to kind of end on the experiences and the learning really from Daska's case, which has, as I said, led to many changes in healthcare provision within the UK. So I'll stop there, thank you, and I think I've got time for some questions, hopefully.
Thank you so much. That was very informative. And yes, we have some questions coming up, and several of them actually are about domestic violence. So we can assume that it's not pregnancy, but domestic violence that leads to suicide. They think something will change after delivery, but their hopes don't fulfill. Could you say that it's a correct observation?
Yeah, I think it's a bit of both. So I think domestic violence and abuse are a risk factor, for in pregnancy and outside of pregnancy. I think definitely there is this case of perhaps people might be hopeful that things will change, and things don't within the postnatal period. We do see actually a slight increase in domestic violence, particularly amongst those with mental health conditions during pregnancy. So I think there's also something about the perinatal context that if you're in a difficult relationship, that might actually trigger domestic violence and abuse as well, and the situations where you're at home, for example. So I think it's a big part of the context of perinatal suicides.
And then there is one sort of follow-up question. In your presentation, the main risk factors related to suicide were domestic abuse and living in disadvantaged areas. Why are the prevention measures in the suicide prevention plan focused only on the mental health issues, but not on the social determinants? What are your thoughts on that?
Yeah, I think generally the suicide prevention strategy has to be, and it has to be universal. So it has to look at all of these factors. And I think what we can do at a kind of universal level of looking at those kind of social disadvantages, social economic factors are quite different from what we can put in practice within a healthcare setting. But it absolutely needs both of those. So it needs those societal changes in terms of economic risk factors, and domestic violence need to be, but we need to be better at kind of recognizing these risk factors in healthcare settings, and better at kind of making sure that if people are in those situations, that they're receiving adequate treatment. So I think any comprehensive suicide prevention strategy, it needs all of that. So I hope that answers the question.
Yeah. Okay. And the other question is a little bit on different aspect. Could you elaborate more about the findings that perinatal suicide methods are more violent than non-perinatal ones?
Yeah, this is something that's come out from all of the Embrace inquiries, that they tend to be of a more violent nature. And I think really that indicates just the severity of the suicide attempts and suicides in this group. They're often within the context of the violent suicides within a postpartum psychosis. So I think that's something that contributes to that. And in the study I showed amongst those with mental health service use, so from the homicide and suicide inquiry, what they found is actually that when they adjusted for all of those clinical characteristics, that the difference wasn't as large. So really, I think it is due to some of those clinical characteristics, so the severity of mental health difficulties that we see and how they kind of play out within the perinatal period, and particularly the postnatal period, where mental health can deteriorate quite rapidly compared to outside the perinatal period.
Okay, thank you. One more question. I wonder how religious those women were. I mean, if we try to look at miscarriage and highly Catholic surrounding, where women's role are strictly described as someone who delivers children, there might be some thoughts in women's mind that she is not worth as a woman in God's eyes.
Yeah, I think it's a really important point, actually, and we didn't look at that in our particular study. Culture, society factors are really important. It will be different in different settings, but there has been some research that's shown that in the perinatal period that actually religious and spiritual beliefs is something that can contribute to it. And I think that it speaks to one of the most common factors that we heard from women is this sense of really feeling like a failure. And that can come from yourself, but it can also come from society and these wider factors. So I think it's certainly something that is part of the picture. Okay,
thank you. One more question. How could have their partners helped?
That's another very good question. I think what partners are very important. So, I think we've focused on domestic violence and abuse when there is a lot of conflict in a very difficult relationship, but actually partners are really important for recognizing deterioration in mental health, particularly when people don't have insight and we saw that in the study, although it was very small, of the women who we did the in-depth interviews with. I would say in more than half of those cases, there was a prevention from a partner or a family member. So when they were aware, they did intervene. So I think that support from partners and families is really important, both in terms of being there, but it can also be very tough on family members. I think when somebody's experiencing these kind of prolonged episodes of suicidality, of mental health difficulties. So one of the recommendations that we make is actually having a whole family support system to make sure that partners are supported as well. But I think partners are essential in kind of noticing changes in mental health conditions, changes in sleep patterns, those kind of things.
Thank you. One more question. Pregnancy obviously is a very biological process in itself, and often depression or other mental health problems are seen as a consequences and dramatic changes in hormones and things like that. So based on everything you researched, the studies that you done yourself and others, would you say that it's primary biological factors that influence suicide during the pregnancy, or it's more about social and psychological, or it's difficult to say?
I think it's difficult to say. I think it would be helpful to have a clear answer to that, but I don't think we do. The hormone changes obviously play a role. I think when we talk about kind of the early postnatal period, it's very common that women are going to experience bouts of low mood that are directly related to hormone changes. But there's a lot of social factors as well that contribute as well, and not all women are at risk who have those hormone changes. So there's genetic factors that might lead to increased risk of severe mental health episodes, for example, and that may interact with hormone changes in the postnatal period. But I think the social factors are important as well. We often hear that women's symptoms are overlooked, so for example, because they're attributed to pregnancy and hormone changes. So I'm just cautious about attributing too much to it. For example, when severe sleep deprivation, we know that new mums don't get a lot of sleep. They're having to care for their baby as well as themselves, but actually that's severe sleep deprivation that we see in the postnatal period is a high risk for suicidality. So I think we just need to be cautious about putting everything down to hormones.
Okay, thank you. One more question. We often talk, at least here in Lithuania, about postnatal depression. But some experienced clinicians say that we should worry maybe even more in terms of suicide and women taking with them their babies as well, dying together. We should worry more about postnatal psychosis.
Yes, yeah, I think postnatal depression is more common, so that's why we do see that in the statistics, for example, many of the women were experiencing postnatal depression, but there's a particular risk that comes with an acute onset of postpartum psychosis that I think is associated with suicide, and the very rare cases of those who also take the lives of their babies that are typically more associated with a psychotic postpartum psychosis episode. So it's really that those women who have a high risk, who have a family history of psychosis, a family history of bipolar disorder, for example, that you might want to be kind of looking at, particularly in the postnatal period.
Yeah. Okay. Thank you so much. The questions are coming even more, but we have to stop at some point. We have to have a break, and we have to thank you for your presentation and for answering all the questions that we had to you. So thank you very much for this.
Oh, it's great. Thank you. Thank you for inviting me along today.